Apologies to the panel who waited so patiently while Mr. Camp and I named 3 post offices after deserving citizens. We can get back now to the important matters at hand. We're privileged to have with us Dr. Byron Thames, who's a member of the Board of Directors of the AARP from Orlando, Florida. Mr. Mattis, do I pronounce that? Mattis. Mr. James Mattis, who's President and CEO of the Grand Rond Hospital of La Grande, Oregon. Mr. David Lipschitz, who is Interim President and CEO of the California Health Advocates from Los Angeles. And Dr. Daniel C. Lyons, who's Senior Vice President of Government Programs of the Independence Blue Cross in Philadelphia, Pennsylvania. I'll ask you gentlemen if you'd like to proceed in the order that I recognized you, and without objection, all of your prepared testimony will appear in the record, and if you'd like to expand on it or enlighten us in any way, and then we can further get information during our inquiry. Dr. Thames.
Thank you, Mr. Chairman, members of the committee. I'm Byron Thames, a physician, member of the Board of Directors of AARP. We thank you for the opportunity to present AARP's views on the Medicare Advantage program. Let me begin by reaffirming a core principle. AARP is committed to the Medicare program. It's a vital component of financial retirement security for older Americans and many with disabilities. I also want to reiterate our support for Medicare Advantage. We believe it's important for people on Medicare to have genuine choices of how they receive services. To this end, beginning this year, most of United Healthcare's coordinated care Medicare Advantage plans will carry the AARP name. We emphatically believe choices must be genuine, options should differ from one another, and each offer high-quality services. AARP believes that MA coordinated care plans hold the promise of improving the quality of care. We are less sanguine about the private fee-for-service option. We did not support its inclusion in Medicare because, 1, these plans are not required to coordinate care for their enrollees or participate in quality improvement activities, two key requirements for other MA options. And 2, these plans can set their own fee schedules and are not subject to Medicare's important balance billing rules. In addition, the marketing of these plans is fundamentally confusing to many beneficiaries. Just last week, AARP was contacted by an anxious member. The hospital where her husband was scheduled for surgery would not accept his coverage once they learned that he was enrolled in a private fee-for-service plan. This member didn't realize that the plan she enrolled in was not a supplement to traditional Medicare. She believed that she would still be able to freely choose doctors and hospitals. The marketing materials did not make the difference between traditional Medicare and the private fee-for-service plan clear. There are numerous reports of fraudulent marketing where beneficiaries have received inaccurate or misleading information about private fee-for-service plans. AARP urges action that will put a stop to these practices once and for all. We commend CMS for the steps it took last summer to curtail questionable tactics, but further steps are needed. My written statement includes specific recommendations intended to improve consumer protections in the Medicare Advantage market. AARP also believes that Medicare Advantage plans should coexist with the traditional program on an equal footing. Currently, payment rates are on average skewed in favor of MA plans. This does not make economic sense for the program or for the people in traditional Medicare who pay higher premiums for benefits they do not enjoy. MedPAC reports that on average, payments to private fee-for-service plans exceed payments in the traditional program by 17%. We see no justification for the substantial excess payments. Furthermore, because private fee-for-service plans are not required to coordinate care or participate in quality improvement activities, we question what value these plans bring to Medicare. It's not unreasonable to expect coordinated care plans to operate efficiently. We know that many beneficiaries appreciate the extra benefits and modest cost sharing that some MA plans offer. But these advantages should derive from savings from high-quality care, eliminating waste and needless care, and cost-effective plan operation, not from Medicare excess payments that favor only the 20% of beneficiaries who've elected MA enrollment. AARP strongly concurs with the MedPAC recommendation of payment neutrality for all Medicare coverage options. Payments can be reduced gradually without undermining beneficiaries' confidence in MA. In summary, it's fair and reasonable for Medicare Advantage plans to bring real value to Medicare by providing high-quality, cost-effective, and efficient care. We look forward to working with you and your colleagues on both sides of the aisle on policies that improve the options offered to Medicare beneficiaries. Thank you, Mr. Chairman.
Thank you, Doctor. Mr. Mattis?
Good morning, Mr. Chairman and members of the subcommittee. Thank you for inviting me here today to tell the story of our hospital's experience with Medicare Advantage plans. Grand Run Hospital is a community-owned, not-for-profit, 25-bed critical access hospital. We're located in the beautiful Blue Mountains of Northeast Oregon in remote, rural, and isolated Union County. The closest tertiary facilities are located over mountain passes in Boise, Idaho, 177 miles to the east, and Portland, Oregon, 259 miles to the west. The 3 closest hospitals are an hour or more away, providing the weather is good. Travel during the winter months is treacherous, and a normal winter storm can shut down the highways for hours. My priority first concern is for the people we care for in our hospital. A large number of seniors who have enrolled in Medicare Advantage plans, about 1/4 by our count, do not realize they have opted out of traditional Medicare. The senior citizens and providers of Union County are overwhelmed with 21 Medicare Advantage plans. We routinely counsel and assist confused and frustrated beneficiaries, many of whom thought they were signing up for a Medicare supplement, drug benefits, or some other supplemental coverage. Our experience with beneficiaries also shows that Medicare Advantage plans are unresponsive when it comes to resolving problems or answering routine questions about coverage. Poor customer service by multiple plans leaves my staff picking up the slack in helping seniors to resolve claim and coverage issues. This means my hospital is effectively helping foot the bill for these plans, while at the same time they're being paid more than traditional fee-for-service Medicare. Also, some senior citizens end up subsidizing Medicare Advantage plans. Several of our sickest and poorest patients who require frequent care end up paying more out of their own pockets because of daily hospital and home health co-payments. You can imagine how upset a patient can be when on top of the trauma and anxiety that an illness or injury can cause, they must pay more out of pocket than they had anticipated. The Consumer Advisory Unit of the Oregon Insurance Division recently issued a consumer alert advising seniors that some unscrupulous insurance agents are preying on seniors by using tactics that are confusing and misleading. Many of the abuses are occurring in the marketing and selling of Medicare Advantage plans. One example of such abuse in Union County is the churning of Medicare plans sold to seniors. Observations on the part of my billing staff suggest that the majority of Medicare Advantage enrollees are sold a new plan every year. Beneficiaries also are swept into problems created by Medicare Advantage plans. These plans have unusually high error rates, which delay the payment of claims and frustrate beneficiaries and providers. In a recent routine compliance audit, our facility randomly sampled Medicare Advantage payments and found the insurance carrier payment error rate exceeded 38%. Our hospital staff must review every claim for accuracy and often must spend weeks or even months making phone calls and writing letters to straighten out a patient's account. When they do finally decide to pay a claim, they do not pay us electronically, even though the claim was made electronically. Compared to traditional Medicare, it takes roughly 3 times as long to receive payment, which compromises provider cash flow. Mr. Chairman, I want to take a step back for a minute and look at the impact of Medicare Advantage on providers, and then I'll close. The capitated rates paid to Medicare Advantage carriers in many rural communities are well above costs. With the mission of maximizing profits, Medicare Advantage insured carriers have a strong financial incentive to focus their marketing efforts on the most profitable regions of the country, which may explain the extraordinary levels of enrollment in Union County, Oregon. As enrollment grows into Medicare Advantage, I'm concerned these carriers will use market leverage to force discounts and provider payments, which will hurt small and rural hospitals and ultimately the patients who depend on us for medical care. Mr. Chairman, I conclude by saying, quite simply, America's elderly and disabled deserve better. Medicare Advantage plans confuse and frustrate them, and poor communications and poor support leave them feeling abandoned. In many cases, they're unable to make an informed decision. Beneficiaries often end up bearing risk without an adequate understanding of whether or not they may be better off financially if they stayed with traditional Medicare. Rural hospitals and physicians also deserve better. The unchecked growth of Medicare Advantage plans and the rapid displacement of traditional Medicare is disrupting the healthcare mission of hospitals and physicians. Medicare Advantage plans underpay critical access hospitals. In defiance of congressional intent, Grand Run hospitalists could soon exceed $1 million per year. To sum up, these plans are hurting rather than helping some seniors in hospitals, and they're increasing the cost of care for everyone. Thank you.
Mr. Lipschutz?
Chairman Stark, Ranking Member Camp, distinguished committee members, thank you for the opportunity to testify today. My name is David Lipschutz, and I am interim president, CEO, and staff attorney of California Health Advocates, an independent nonprofit organization dedicated to education and advocacy efforts on behalf of Medicare beneficiaries in California. Our experience with Medicare is based in large part on our close work with California's state health insurance program, known in our state as HICAP, which is on the front line assisting Medicare beneficiaries. Of the various options within the Medicare program to access benefits, we recognize that some Medicare Advantage plans can work for some individuals. Other Medicare beneficiaries, however, can be disadvantaged by joining MA plans for a variety of reasons, including restriction of access to providers, high out-of-pocket expenses, and other barriers to care, such as utilization management. My testimony will briefly focus on general issues faced by MA plan enrollees, new insurance products being sold to fill in the gaps of MA plans, and the experience of dual eligibles who enroll in MA plans. The staggering rise in the number, type, and variation of MA plans over the last 2 years, coupled with aggressive and misleading marketing, has greatly hindered the ability of Medicare beneficiaries to make informed decisions about how they want to access their Medicare benefits. Many beneficiaries are lured by MA plans with zero or low monthly premiums, corresponding offsets of their Part D premium, and extra benefits of often limited value. Once enrolled and in need of services, however, many find they are liable for cost sharing on a par with or even greater than original Medicare. Since MA cost sharing is commonly downplayed during sales, those with chronic conditions can face catastrophic costs they hadn't anticipated and realize too late that they would have been better off financially by purchasing a Medigap policy. For example, a HICAP counselor in Southern California who has extensive experience working with individuals with cancer reports that most MA plans she deals with are charging at least 20% in cost sharing for chemotherapy and radiation. Enrollees in these plans who receive cancer treatment often have thousands of dollars in monthly out-of-pocket expenses. Most cancer patients in this situation report that when they signed up with their MA plan, they thought that the co-payments for chemo would be between $35 and $50. Many tell the counselor that they would rather die than leave their families without money. Some who join MA plans are surprised to learn that providers who they had seen for years are not members of the plan's network, or, particularly in the case of private fee-for-service plans, refuse to accept the plan's terms and conditions, leading to problems finding doctors who will treat them. Over the last year, much attention has been focused on appalling abuses surrounding the sale of Medicare Advantage plans. Despite this attention, though, we believe that far too little action has been taken by CMS, and as a result, such abuse appears to continue unabated. Despite industry claims that MA products are good value for all beneficiaries, significant fissures in MA plan coverage have led to the emergence of a new insurance product aimed at filling those gaps. This product, sometimes called Advantage Plus, is designed to fill in the gaps in MA plans, including high out-of-pocket expenses for vital services such as inpatient hospital care, skilled nursing facility stays, durable medical equipment, and drugs covered under Medicare Part B. We believe that the existence of these products is a symptom of a more widespread disease afflicting the Medicare Advantage program and underscores how far too many MA plans impose high cost sharing while providing inadequate benefits. Individuals who are dually eligible for Medicare and Medicaid are entitled to a broad range of benefits provided by both programs. Enrollment in Medicare Advantage plans, though, can create problems for dual eligibles, such as access to care issues and greater out-of-pocket expenses. Medicare Advantage Special Needs Plans, or SNPs, are, in theory, designed to address the needs of duals and other designated populations. Without formal requirements mandating that they provide care coordination, integration with Medicaid, and targeted case management, often SNPs remain special in name only. Unfortunately, many duals who were automatically enrolled in SNPs over the last 2 years have experienced significant problems with accessing care and coordinating coverage and payment with state Medicaid programs. Other MA plans, notably private fee-for-service plans, are generally ill-suited to address the complex needs of dual eligibles and often cause harm to this vulnerable population. Dual eligibles are targeted by some PFFS plan sponsors and agents without regard to the suitability of such plans, including meaningful comparison with Medicaid benefits already available to them and access to providers who accept both Medicare and Medicaid. Instead, duals are being targeted and convinced to enroll in PFFS plans based upon extra benefits that agents and plans say will save them money. Once enrolled, however, duals often find that their doctors won't take their plan and they are charged cost-sharing for services and items they did not previously have to pay for. We recognize and appreciate that the CHAMP Act would have addressed some of these problems, and we are disappointed it did not become law. For our specific recommendations on improving the MA program, we refer you to our written testimony and the various documents cited therein. Thank you.
Thank you very much. Dr. Lyons?
Thank you, Mr. Chairman. Ranking Member Camp and members of the committee, my name is Daniel Lyons, MD, and I am Senior Vice President of Government Programs for Independence Blue Cross, and I do appreciate the opportunity to testify about the Medicare Advantage program. Independence Blue Cross is strongly committed to the long-term success of the Medicare Advantage program. We are proud to sponsor plans that offer many services and innovations that are not included in the Medicare fee-for-service program. Approximately 240,000 Medicare beneficiaries in Philadelphia and southeastern Pennsylvania are enrolled in the plans we offer. Our Medicare Advantage plans serve a critical role in providing comprehensive, coordinated benefits for many seniors and disabled Americans. The fundamental difference between Medicare Advantage plans and the Medicare fee-for-service program is that our private plans have established an infrastructure for improving health care quality on an ongoing basis. At Independence Blue Cross, our plans focus on identifying members with important clinical needs, including those not receiving preventive care, those who are frail, and those with chronic illness. Because Medicare Advantage plans do have an infrastructure to coordinate and improve the care for these members, we have a proven track record of making a positive difference in the lives of Medicare beneficiaries. Many Medicare beneficiaries do suffer from multiple chronic conditions such as diabetes, heart disease, cancer, asthma, depression. One recent study suggested that over 80% of beneficiaries have at least one of these chronic conditions. Medicare Advantage plans are playing a leadership role in developing strategies and programs to improve patient care for beneficiaries with multiple chronic conditions. We're focused not only on ensuring that patients with chronic conditions live longer, but we are also helping them live healthier lives with fewer symptoms so they can fully participate in the activities they enjoy. Our Medicare Advantage members benefit from a variety of programs we've developed over the years to improve their care, including the promotion of prevention and wellness. For example, our Connections Health Management Program is designed to help our Medicare Advantage members by making them more informed about their health conditions, assisting them in making difficult treatment conditions, helping them and their physicians improve the management of chronic conditions, and assisting members, their physicians, and their caregivers with the coordination of care. Through this program, we use sophisticated predictive modeling tools to identify those members who are at highest risk for future health events and identify specific gaps in care and to fill those gaps. Specially trained health coaches, typically RNs, are available 24/7, 365. They do telephonic outreach to these members to address their care gaps, help them understand their physician's treatment plan, and improve self-management of their chronic conditions. The results of this program are very impressive. In 2007, our member satisfaction survey showed that 94% of members were satisfied with their health coach assistance, 90% were satisfied with their overall program experience, 94% they said they'd recommend the program to other seniors. Moreover, 97% of members with chronic conditions indicated they were able to follow their health coach's advice. Nearly 80% reported an improved ability to communicate with their physician, and nearly 60% said that speaking with a health coach actually improved the quality of care they received from their health care provider. Medicare Advantage members have also enthusiastically embraced our wellness programs. More than 9,000 seniors are enrolled in fitness programs we've designed to encourage and promote healthy, active lifestyles. Almost 60% of these seniors complete the program target of 120 visits a year, which is twice the rate of non-Medicare members. Another program we implemented for Medicare Advantage members is our physician home visit program. Under this program, a physician conducts a proactive home visit to assess members who are homebound and then provides follow-up care as needed and also coordinates care with the member's primary care and specialty physicians. This program is designed to improve the control of chronic illnesses and reduce the use of emergency services for medically frail members. We also work on an ongoing basis to provide Medicare Advantage members with access to care coordination throughout their health care experience. For example, when a member is scheduled for an elective admission, such as a total knee replacement, we reach out, identify their anticipated post-hospital needs, coordinate with their surgeon, begin to make arrangements for post-hospital care, such as rehabilitation, long before the member ever goes to the hospital. This sort of care coordination, like our wellness, disease management programs, are not currently available in traditional Medicare and not readily created without considerable planning and investment. In fact, when you consider the array of health infrastructure investments and improvements we've implemented over the past decade, credentialing a system of quality checks on physicians and providers that includes checks on medical records and office adequacy, physician performance monitoring and quality incentives, coverage and promotion of preventive medicine, fitness, smoking cessation, weight management and related programs, health education, nurse counseling, disease, condition management, medication and therapy management, case management, home visits, etc., you can begin to understand the extent of the planning investment required to bring these kinds of advancements to the entire Medicare program. Thank you for this opportunity to testify on the Medicare Advantage program. We appreciate the opportunity and urge the committee to continue to support adequate funding for the system of competition, choice, and innovation that's delivering savings and value to nearly 9 million Medicare Advantage members.
Thank you. Dr. Lyons, were you guys in business in 1997?
Yes, sir.
And you were offering those same services to your members in 1997?
Some, not all. Yes.
But you offered them. You offered the same kind of a program that you just outlined.
We did not have our comprehensive connections program at that time, Mr. Chairman, no.
How about in 2003?
It was not as robust as it is today, no.
All right. Let me just run down the line, and I know you don't like to cheer for your competitors, and they're not really your competitors, but Pilgrim in Boston, Puget Sound in Seattle, Kaiser in California, Ford in Michigan, Marshfield Clinic in Wisconsin. Would you say they're all similar to the kind of a plan you just outlined?
I think they do. They're well known for their quality, sir.
No, but they have the same general disease management and all of these things that...
Many of them do. NCQA now, certifies these kinds of programs and organizations. We all submit data to them.
And they were all chugging along in 1997, fat and happy at 95% of the AAPCC. And many of them, I'm aware, operate at less than 100% of AAPC. Why should we pay them any more?
The investments that have been made in systems that aren't tied to delivery systems that are more open, are substantially more. It's much harder, actually, to engage physicians who aren't on your payroll, who actually aren't part of your delivery.
Well, not all of these guys have docs on their payroll. Kaiser does. It's a staff model, but not all of them do.
No.
Many of them operate as managed care plans, and I have trouble. Are you familiar with what's referred to as boutique medicine as provided generally by primary care docs?
Is that where physicians opt out of the Medicare system and take a...
Or if they're not in the Medicare system, they charge you maybe $1,500 and you get 24/7, you get their home phone and...
That sort of, arose a few years ago. I haven't heard a lot of it recently.
Okay. Well, it could be done. When I go into Medicare, it'll cost you taxpayers $9-10 grand a year. And so for 15% over, I could get a boutique and have a full-time, just like the president or somebody else or a movie star, have a full-time physician, basically. And I think that's great. I just guess I have trouble figuring out why we would pay for it, and I'd ask Dr. Thames. United Healthcare basically is the insurer with whom you contract. Is that correct?
Yes, sir.
And they sell a Medicare Advantage. They provide you the Medicare Advantage policy that you put your name on, and if I buy a membership, I can get it through you, but it's basically operated by United Healthcare. Is that?
You get it directly from them. We don't sell any policy.
And they don't offer the private fee-for-service plan, do they?
That is absolutely correct, sir. It's against our policy to support private fee-for-service plans.
And I think that I recall in this conversation some time back that Mr. Novelli, your chief executive officer, said to me, and I don't think I'm quoting him out of context, incorrectly. If I am, you should let me know, and I'll set the record straight. But that he felt that that they should provide these plans at no more than 100% of fee-for-service costs.
That is correct, Mr. Chairman.
Okay. So I think you're to be commended for that, and I'm sure that is Independence Blue Cross going private? You're going to become for-profit?
No, sir.
No.
No, we are merging with Highmark Blue Cross.
And are they not-for-profit?
They are also a hospital charter organization, just like we are.
You're going to stay nonprofit?
Yes, sir.
Good for you. Mr. Mattis, in your hospital, how many physicians have privileges there?
We have 43 on our active medical staff.
Okay. A lot more in the community than that?
No, that's the entire county.
That's kind of interesting. You got 43 doctors and 21 plans.
And only 25 beds in the entire county.
Do you need one plan for every 2 doctors?
Well, I was thinking the same thing. Actually, we believe there will be more plans. We are aware of some that are being sold, in addition to the 21 that have actually hit our door.
Okay. As I say, does it really offer a lot more choice in your, what we'll refer to as a rural community without demeaning you, I'm sure?
Well, there's choice in plans, but not choice in providers in reality.
Yeah,
because we live in an isolated part of the state where they have to travel.
Does every plan let you have every doctor?
Yes.
Okay, so none of you. If I signed up with any one of the 21 plans, I wouldn't be denied the opportunity to see any one of the.
Well, I'll take that back. One of our plans is a PPO plan.
Okay.
So that one has to have members signed up for participating members in the plan, and I don't know whether all of them are signed up for that one or not.
Okay. I guess I wanted to ask Mr. Lipschitz. In California, I know that we have attempted over time to deal with marketing, and I don't know what the restrictions on these types of policies, I don't know what you call them, like AFLAC, where you get sick, you get $50 a day, and those are the types of plans you're referring to that are sold under the guise of being Medigap. Is that, am I?
These Medicare Advantage gap plans that we learned about are essentially limited benefit plans that are bundled together, such as hospital indemnity plans, plans that'll pay out.
But just help me here a minute. They don't offer anything but a fixed amount per day, regardless of what triggers it. Otherwise, it would seem to me they'd come under the Medigap rules.
Correct. It's our understanding that the current anti-duplication provisions in federal law apparently allow the sale of these types of products.
Because all they offer is so many dollars a day.
Or pay out a cash benefit. Yeah.
Pardon?
They pay out a cash benefit when people
That's it.
incur.
And you can then spend the money any way you want. They don't send it right to the doctor or the hospital. They just send you a check for X bucks a day.
Correct.
But I think what your testimony was saying, they are thinly disguised or suggested in the marketing approach that they are Medigap, as people remember buying it from AARP or Blue Cross or whomever. Is that what?
I would
say, is that a fair assessment?
Based on what we have found in advertising, it looks like to beneficiaries, it's pitched as just limited benefit plans that'll pay out cash benefits when you need services. But to agents selling the plans, it's clearly pitched as a plan meant to fill in the gaps of Medicare Advantage and meant to be sold along Medicare Advantage plans in order to fill in those gaps.
You're familiar with the California Insurance Commissioner's Office?
Yes.
And you've been doing what you've been doing under both Republican and Democratic administrations when John Garamendi was insurance commissioner. I don't know who he is now, but
Steve Poizner.
Do you find them to be pretty even-handed, pretty effective, pretty good at governing insurance agents and practices?
As far as we can tell, yes. However, in the Medicare Advantage context...
Keep going.
All right. I was going to say...
Let me ask the question. It sounded like I figured it out, but you go ahead. I know what you're going to... Go ahead.
Thank you. In the Medicare Advantage context, the jurisdiction of state departments of insurance is by and large limited to the regulation of insurance agents selling Medicare Advantage products, and the individual state departments of insurance have very little jurisdiction over the actual Medicare Advantage plans themselves and Part D.
Let me say it another way, because Mr. Pomeroy would say the same thing, and I think it's an important distinction here. And see what CMS can regulate the plans, and CMS federally can fine Dr. Lyons' plan or United Health, but CMS can't, if Dr. Lyons' company were to employ a broker, an independent agent. I don't. Do you do that? I guess I would presume.
No, we have our own staff.
You sell all direct. You don't allow insurance brokers to sell.
Within our market, our market area, we only have our own staff.
Okay. Other blues do. Though other blues allow brokers. And what I'm trying to get at is, the federal government has no ability. They can punish Dr. Lyons' plan, but they can't punish or regulate the individual independent brokers or agents. And it's often the plans who have great intentions, but then they pay a commission to any salesperson operating under state licensure who are very aggressive, probably good at what they do, but sometimes they may cut a few corners on explaining benefits and selling in the best interest of the consumer. And I just wanted to see if you'd agree that that would help us in California if somehow we could let the state commissioners, who, at least in California, I think, I'm sure in Pennsylvania they do as well, regulate the sales practices. And would that, well, it couldn't affect your plan, correct? I mean, because you do it directly anyway. Would it affect your plan, Dr. Dames, if the states in which you operate?
Mr. Chairman, it could affect it in Florida. On the other hand, we don't allow all agents of United to sell AARP products. We have special requirements of the agents that sell those products. They're required to do outbound follow-up calls after sales.
Would it trouble you if the various state insurance commissioners were?
No, sir. It would not trouble us at all.
I guess that's the point I was trying to get at, is that the companies can have the best intentions but can't often control the independent agents, certainly as you do, and that might be an advantage. Thank you all for your testimony. Mr. Camp, would you like to inquire?
Yes, thank you. I would agree that Mr. Pomeroy has a good point, and I spoke to him informally after he made his comments. Dr. Lyons, you were beginning to sort of talk about the costs of engaging doctors not on your payroll. Could you just elaborate on that a little bit? I don't know that we got the complete thought there.
No, thank you, sir. In order to set up systems of care, particularly systems that monitor quality of care and promote continuity of care, you either have to, A, have physicians who are aligned in a system because of contract or economic incentives, or B, you have to put an infrastructure in yourself, and we've done the latter, and that's what many plans have done over the past 5 to 6 years, put in extensive infrastructures of quality management, care improvement, to act as sort of an overlay to the system to promote quality. And if I may just briefly continue, there's no question that there's good evidence that this does work. We see sequential and statistically significant improvements across a wide variety of care outcomes. There is very limited opportunity to compare our care outcomes with fee-for-service, but when those comparisons have been made, for example, in the well-cited study by Stephen Jenks in 2003, there was no question that Medicare Advantage plans in general produce better clinical outcomes than were extant in the fee-for-service system.
All right. Thank you. Mr. Matt, as you mentioned, I guess in response to Mr. Stark's inquiry, that because there are 21 plans and they cover all your doctors, that they don't really negotiate much in terms of discounts. Yet in your testimony, you said Medicare Advantage carriers will use market leverage to force discounts in payment rates. And then you go on to say that those are provided to beneficiaries, but that hurt small hospitals, such as yours. But clearly, are they negotiating discounts and leveraging, or are they not?
Representative Camp, the comments in my testimony were prospective. We're not negotiating with any of those plans other than we have one PPO contract. However, it's my understanding that fee-for-service plans can, when they aggregate enough volume, initiate negotiations with providers, and our fear is that they will attempt to leverage us in those negotiations.
So you're concerned that this is in the future, if this plan is allowed to continue, they'll actually negotiate discounts for their beneficiaries in some fashion. Dr. Lyons, can you briefly also explain a little more detail, some of the benefits your plan offers that traditional Medicare does not, and efforts in terms of coordinating care and wellness?
Yes.
If you could just comment on those, I'd appreciate it.
Yes, you're welcome, sir. I'd sort of put them in 3 categories. At the front end are prevention and wellness services that are not provided to fee-for-service beneficiaries. This would be coverage for services that are needed to prevent disease and illness, reminders and promotion of those services, and then a fairly broad array now of what we would call lifestyle modification programs, smoking cessation, fitness. Probably our most popular benefit is our fitness program, free gym membership to seniors. And of course, obesity and weight management, currently the biggest epidemic. In the middle is a series of programs that are largely educational in nature and fairly broad-based, but they also allow members who do have specific conditions. We currently have developed clinical modules for 21 clinical conditions that actually have very intensive education and coaching. More serious events such as prostate cancer, breast cancer, so forth and so on. And at the third level, for folks who are actually engaged in a chronic illness and are significantly ill or disabled, we have much more extensive programs with extensive literature, one-on-one coaching, and so forth. So that's kind of at the core. More recently, as we've sort of tried to work with our delivery system, sort of fill in the holes and gaps that we see, particularly around frail elderly care, our homebound physician program.
Thank you, and I don't mean to interrupt. I'm running out of time, but does this comprehensive approach, is that successful in keeping patients healthy and out of the hospital? And if so, has that reduced costs?
Yeah, it both. It both improves clinical outcomes. We measure them regularly. We report them regularly. And we do have data that shows that there have been statistically significant reductions in both in- and outpatient care for the managed population compared to the non-managed population in each of the 3.5 years since we launched our robust programs.
And is traditional Medicare capable of offering programs like that?
No, I don't see how the program could. I'm privileged to serve on the advisory panel for Medicare education, and I actually have chaired the panel the past 2 years. So I have a wonderful window seat to see all of the wonderful innovations that the fee-for-service program is bringing. But to get to that level would take substantially more investment time and a different approach.
All right, thank you. Thank you, Mr. Chairman.
Ms. Schwartz?
Thank you, Mr. Chairman. Appreciate it. And I thank all of the panelists. And did want to start with, I guess, my own homegrown, not a constituent, I don't think, necessarily, Dr. Lyons, but...
Almost. I'm just over the line.
But certainly want to talk about some of the things that you've talked about, and hopefully be able to talk a bit more about some of the private fee-for-service plans, which I know you are not talking about. But I was interested in the fact that I wonder if you could give us more information about some of the successes. I mean, you really talked, and many of us here, the only real statistics we end up hearing about the success of more managed programs and more prevention are really patient satisfaction, which is a piece. That's fine. But really, I think one of the things we ought to be really concerned about is actually have we really improved outcomes? Have we are people, their health status improved, actually, and are we doing it in a more cost-efficient way?
Yeah,
that would be helpful to know. Do you actually have hard data on that? And why don't you answer that first, and I wanted to know how much more it costs.
Yes, ma'am, we do. We have data about all three of those arenas. So when it comes to, does the systems we use to promote prevention, do they work? And I'd say that the two major pieces of that are we actually measure and monitor and reward primary care physicians for superior performance in preventive care. So that would be programmatically what we do, number one. And then number two, we have extensive outreach campaigns with members to promote the use. And we use a scientific survey. We report the data publicly, and there's been significant improvement from the times that we started the programs. And also, if we do plateau, we gather clinicians, and just as an example, some years ago, it was very clear that there just wasn't enough interest in the radiology community to provide basic mammography any longer. It just wasn't something they were, so we brought them together, brainstormed, and improved some access issues. And so, yeah, we can show you how that over time.
I would be interested to see some of that hard data, because otherwise it's really so much on. You're not required to give that, though, to CMS or to the government.
Well, actually, yes. Right. We do report all of our clinical outcome studies via NCQA to CMS, and also via annual, including utilization data. I know that came up earlier, but we do provide utilization data.
There's a lot of utilization data we don't actually get so much, but it's utilization is different than outcomes. So, and that is something that we're really interested in. Can you tell us how much more you get paid under the Medicare Advantage?
Well, I'm not an actuary. But what I would say is that...
Well, we know on average, nationally, we're paying 12% more. Right. Are we paying you 12% more for Medicare Advantage?
No, we do not think so. Our actuaries do not think that the overpayment in our market basket, the 5 counties of Philadelphia, even approaches that much. And what we really focus on, because we are a legacy plan who've been out there for a long time, is really what happens, year over year. For example, in 2007, our payment increase from CMS was 0. It was flat. We got nothing at a time when healthcare cost inflation in Philadelphia, which, as you know, is medically rich. It's really...
We have great assets.
We have great assets and high use of great assets. And so our own...
You're saying you don't know how much more you get paid for Medicare Advantage than...
Well, no, as I say, our own studies think that it's a trivial difference, that the difference between Medicare fee-for-service, given a lot of the complexities and nuances about our payment stream, is very little different from fee-for-service beneficiaries. And what we do know is that medical inflation in Philadelphia typically runs anywhere from 6 to 8%, And when that gap intrudes itself, we have nowhere to go.
Yeah, but I'm sorry, that's not the question I'm asking. I mean, we actually have a president's budget that is not acknowledging any medical inflation at all. So, inflation and medical costs, they're actually either flat funding or cuts, and they're, so that's really barely on the table. I mean, we're actually raising that as whether that's reasonable. But my real question is that you're providing these additional services. Well, actually, you didn't really say they were, some of them are services, but you're not, how much more does that cost you to do that? You can't tell us that? Or you don't know it?
I know what our administrative costs are. I do know that. As to the question of how our payment rates relate to the fee-for-service system, I don't have a specific answer, but I could certainly find out.
One of the things we are obviously concerned about and interested in is that if we're paying, the public taxpayers paying more money to get services to Medicare beneficiaries, to just some, about 20% of our beneficiaries, we want to make sure that we're using those dollars well, right?
Very reasonable.
And if, in fact, it is really wonderful and working, then why doesn't everybody get advantage of this? I mean, what most of the Medicare Advantage plans, I'm assuming you have said, and yours as well, is that you can do more for the same amount of money by managing it better, by being smarter, by being more efficient, by doing prevention, right? And then they come back and say, we still need more money. So it's kind of inconsistent. We're trying to figure out whether there's a way to actually say, if you really are saving lives, keeping people healthier, having better outcomes, then you're saving some dollars. So why do we actually have to pay you extra for that?
I think, again, these are complicated questions. There's no simple answers to them. But my own perspective is that the system itself is very badly flawed. In other words, the overall healthcare delivery system, we're just a part of it. But we operate with a much larger system with all sorts of incentives that are not particularly well aligned with quality and accountability, all of which is very, very well documented in Institute of Medicine and other reports. So we're a bit swimming upstream, doing the best we can.
Well, I understand. Actually, I think you're being incredibly modest. For those who don't know, Independence Blue Cross is a huge percentage of the marketplace in southeastern Pennsylvania and is a very big player in potentially making big differences in creating incentives in the way we do things. So appreciate your modesty, but I'm not sure that it isn't true that you actually have a very big player in the field here and could actually be very much of a participant. Just one other question. You really talked a lot about prevention. We've been trying to incentivize through Medicare, traditional Medicare, more prevention, more primary care, and creating those same kind of incentives. We've actually had a real pushback from the administration about that and from the other side of the aisle as the potentially not being a useful thing to do. Would any of you think that that's not a smart thing to actually be putting greater emphasis, more resources on prevention and primary care?
Congresswoman, I would put on my advisory panel hat for just a moment. I don't know, candidly, the administration's posture. I know at the panel meetings, we panelists have regularly heard from CMS staff about all of the things they are doing to promote prevention, including systems that would actually somewhat mirror what we do, which is getting out at least reminders and so forth to folks, allowing them to set up, sort of web-based personal health registries and so forth. So I think they are making progress. It isn't anything such as what we have and are developing, but still I think important steps are being made.
All right. I would have many other questions, but I think my time is up, and I yield back.
Mr. Becerra, would you like to inquire?
Thank you, Mr. Chairman, and thank you to the witnesses for your patience and indulgence. We appreciate your being here. Let me begin with Dr. Thames. It's Thames?
Thames.
Dr. Thames, thank you for being here. Private fee-for-service plans, I think you've heard a little bit of discussion about the private fee-for-service plans. I know there's a great amount of concern about the private fee-for-service plans, not only because of the lack of oversight, but because they seem to be providing a lot of offers, but less in actual services and value for service. And so I'm wondering if you can, and if you already answered this, I apologize, but does the AARP's plan that it uses with some of its private insurance company providers work with them to provide a private fee-for-service plan to its AARP members?
Absolutely not. We have a policy, AARP presently and for a number of years, which is not expected to change, that says we do not support private fee-for-service plans, and we don't plan with our present provider to offer any such plans under Medicare Advantage or otherwise.
Now, and if you can do do this briefly. Give me an explanation, because I think most seniors who are listening, who may understand the difference between a fee-for-service traditional Medicare program, which they are accustomed to if they've been on it for a while, as opposed to a health insurance company product, Medicare Advantage, called private fee-for-service. They might think they're getting the best of both worlds. They're getting fee-for-service, but in a private setting. And can you give a brief explanation of why you avoid using private fee-for-service plans?
Yes, sir. I'll try to keep it very brief. First, they're the highest paid of the policies, and again, our policy is for equity and payment as MedPAC and others have recommended, so that's the first thing that would not qualify them.
And when you say paid, meaning government payments through Medicare for the insurance?
18% more than they do for traditional Medicare. Secondly, they are not required to belong to quality improvement organizations, and we believe that that should be part, as it is for the other Medicare Advantage programs, a requirement. Third, they're not required to do coordinated care, and we feel that's very important, both in better medicine and lowering costs for medicine as a whole. And last, or perhaps one of the other reasons, Lise, may not be last, but at least one of the other ones is, from what we have seen, most of the complaints that come in that we've looked at come from problems that are with private fee-for-service plans. And again, another reason is we don't believe in balanced billing for people on Medicare programs.
So I thank you for outlining the Medicare Advantage problems with their private fee-for-service plans. Let me ask you this. As a doctor, if I needed to get a hearing aid, what's the average cost, or what am I looking at in terms of a cost for a hearing aid?
Well, you're looking at, and it's of interest that we are looking at hearing aids because so many of our people want those. You're looking at from something like Miracle Ear or something along that line for just a couple of $100 to the best digital hearing aids that may cost you $2,500 an ear for those. So that is definitely a very high-cost item.
Okay. And so we're hearing more and more about some of these Medicare Advantage plans that are offering these wraparound packages, or saying that they're offering a great deal of benefits if these seniors were to switch over from regular traditional fee-for-service to the Medicare Advantage program. And I have information here about a program in Michigan, a Medicare Advantage plan in Michigan, that lists for those who are thinking of switching over to their plan, that it provides dental, hearing, and vision benefits in their plan. They say that in their plan summary, that they provide those benefits in dental, hearing, and vision, and that there are no co-payments. Obviously, any senior hearing that, no co-payments. I go in, I don't have to fork over any money for going in for that visit or for that particular medical product. But then at the end of the explanation of benefits, at the very end, you read the following. Quote, dental, vision, and hearing benefits are part of the benefit basket. The benefit basket, basket benefit. The basket benefit is capped at $700 annually for all of these services. And so, in essence, what they're saying is that we offer you these benefits. You don't have to pay anything up front. But if you don't finish reading this whole paragraph or this whole page, you won't notice that you only get $700 worth of this. And so if you try to get a couple of hearing aids, you get the cheapest ones, you've already used up $500 or $700 benefit. Forget about vision and contact lenses and dental, that who knows how much it'll cost. But is that the way that you allow any of the Medicare Advantage plans that you work with to market to your seniors?
No, sir. As I indicated a little earlier, we have the only agents for United who can offer our products are people who have had special training on selling those products and being completely honest and fully disclosing to them, and have to take tests and pass those. Secondly, they have to sign a code of ethics. And last, we do secret shoppers from AARP, not from our carrier, but from us, to ask our people and listen in to the sales bits and see if they are really doing what they say they're supposed to do and what they've signed up to do. And then as I indicated earlier, after the falls, we have the outbound follow-up calls that we also require. So we have a limited number of agents within that company who do that, and we hope that we're going to have the highest quality standards in the business.
Mr. Chairman, I know my time has expired. If I could just ask Mr. Lipschutz one question, and that is, you've heard what Dr. Thames from AARP has said, that they undertake to do some oversight of these Medicare Advantage plans. Do all Medicare Advantage plans do that type of oversight?
It's my understanding that no, most of them don't. And looking at the United Health plan that AARP has lent or sold its name to, other products under that umbrella have been a resource of significant complaints in the field of marketing. For example, Secure Horizons products in California, they do sell private fee-for-service plans, and they are targeting dual eligibles in some areas that has resulted in significant harm to beneficiaries.
Appreciate it. Thank you, Mr. Chairman.
Welcome. Acknowledge the presence of our distinguished gentleman from Texas. Mr. Johnson, would you like to add some wisdom to this?
Thank you, Mr. Chairman. I appreciate that. I don't know about the wisdom part. Dr. Lyons Independence Blue Cross provides physicians with information that compares their practice's ability to manage chronic disease against performance of their peers. Do you find that information useful, and do you believe other physicians can learn from those comparisons?
Yes, sir. I absolutely do. We develop those reports with their input, and so we try to make sure at the front end, sir, that this is going to be useful information, that it won't be inflammatory, that it will be helpful to them and actually help them give better care. I don't practice anymore. I did for many years. I practiced in a very rural community. And candidly, I would have loved to have gotten more information about care gaps so that I would have known better, exactly who was getting what and what they needed at the time of their care.
Yeah, that's good. Thank you very much. I'm going to yield to Mr. Camp, if I may, some of our time.
Thank you. Thank you very much. Dr. Thames, do you have information that you can make available to this committee about any concerns you've received from Medicare beneficiaries on any marketing and sales tactics used by AARP's Medicare Advantage plans? Have you got that information?
I don't personally have it, Mr. Camp. I will certainly, and my staff people are here from AARP, go back and see, since we only began to have these programs since January, but I will be happy to provide any material that we have to the committee.
And also to help us evaluate the effectiveness of these plans and the satisfaction people have with these plans.
Sir.
If you have those sorts of complaints or any concerns about people that are in AARP's Medicare Advantage plan that maybe didn't realize they were in it or any of that nature, I think we're very interested in sort of the sales and marketing side of this as well, and I think that's something we want to try to move forward with together. I guess I would just say I appreciate all of your testimony. Thank you very much. Thank you, Mr. Chairman.
Thank you, Mr. Chairman.
Well, I want to thank you. I wanted to explain to the witnesses that for a variety of procedural reasons, the House has finished perhaps an hour ago its formal deliberations for today, I guess for the rest of the week. And so many of our colleagues headed home to escape this wonderful weather. And I want to suggest to you that your testimony is appreciated, the efforts in getting here, and your patience is appreciated. And I hope, although each of you have some different approaches, that just to summarize, I think we could say to Dr. Lyons that all of us appreciate the many advantages that are possible under a coordinated, multidisciplined practice, and we appreciate appreciate groups that have the huge resources like AARP, as well as rural communities that wish they had more resources, and through modern technology and digital imaging may get the advantages of group practice over the internet and in other manners. And then the consumer advocates like Mr. Lipschitz, who are just offer tremendous help to congressional offices who often hear these complaints or hear the bewilderment of seniors wondering what they now have and why they can't see the doctor they saw before, or why Kaiser's raising their rates so much. I don't suppose the Blue Cross does that, but you hear it. And so what we're trying to do is figure out, on the one hand, we're hearing the clarion call that Medicare is going to go broke, and we've got to figure out how best to reimburse all the professionals who work hard to get the best quality we can. And your contributions to enlightening us in that direction are very much appreciated. I want to thank each of you for taking the trouble to be here and helping us. And with that, the hearing's adjourned.